Hey, it's Emma Chamberlain. I designed these new glasses for Warby Parker and I basically can't take them off. Like, I'm showering in them and sleeping in them. They're just that good. Go see them all at warbyparker.com. And you know what? Have a good day too. Okay? All right? Bye.
For over 50 years, Burlington's legacy has been great deals on coats for all weather conditions. So before you're caught unprepared for the winter weather, head to Burlington for name brands, quality items, and surprising fits for every family member. Stock up on coats, sweaters, and accessories before the cold hits, so you can finally stop avoiding the elements and start living comfortably. Warm up at your nearest Burlington location less than 1 mile away. Burlington. Deals, brands, wow.
I'm Dr. Wendy Hunter, and I'm the pediatrician next door. I'm that doctor friend you call for practical advice about your kid's health. I mix the science of medicine with the reality of parenting. This bonus episode is for clinicians or anyone interested in how healthcare providers talk to their patients about this very touchy subject of body weight. Welcome back, Dr. Maya Kumar. She's an adolescent medicine physician and chair of the Eating Disorders Committee for the Society for Adolescent Health and Medicine. She explains that the words we say as clinicians to our patients frames how they think about their weight. We sometimes have a profound impact, especially when it comes to adolescents. Here's Dr. Kumar to explain why this matters.
One thing that is a very difficult fact that we all need to accept is that being identified by a healthcare provider as being overweight or obese is an independent risk factor for developing poor body image and disordered eating thoughts and behaviors. And I think that it's been ingrained in us as, physicians since medical school, and especially in pediatrics where it's all about the growth curve, right? Where you are screening from newborns onward for a high BMI percentile or a high weight for lame. And we're just trained to just spit out when that dot is above the 85th percentile or above the 95th percentile to say I need to tell you that you're overweight or I need to tell you that you're obese. Mm-hmm. And the number of kids I see who carry that with them like a thorn in their side, kind of forever, for many, many, many years. And it just totally changes their perception of my doctor doesn't think I'm healthy at this weight. Yeah. And so one thing that I really encourage my colleagues to do is consider the risks versus benefits of the words that we use. And everything we do in medicine has a cost and a benefit, right? But I think what we need to talk more about is the cost. We hear all about the benefits. Oh, if you let people know that their weight is higher, then they will make changes. I mean, A, I think that's actually not really true. Mm-hmm. And B, we never talk about the fact that using those words, applying that label is actually associated with a huge cost. So one of my recommendations for my colleagues is to kind of approach growth curves with a little more flexibility than just using hard cutoffs. If you have a child who has tracked along the 85th or 90th or 95th percentile BMI their entire life.
That's who they are, right?
Right.
That is their genetic predisposition. That's who they are. That's their family.
That's where they live.
Yeah. Yeah.
That's just where they live, right?
It's that big change that you would worry about.
The changes are much more concerning. So if someone was at a 25th percentile forever and then suddenly went up to the 75th percentile, maybe that should prompt some questions. But if someone is actually maintaining a lot of consistency, I would, and especially if they're otherwise healthy, they have no known metabolic dysfunction, their blood pressure looks fine, and you're satisfied that their nutrition and physical activity patterns are fine, I would say leave that kid alone. Don't bring it up. That we as pediatricians have to be much more careful about the words that we use. Even if you have a child who has high blood pressure, dyslipidemia, an elevated fasting glucose. Like they have all these metabolic markers that you're concerned about this kid's health, which is the counter argument I hear from so many of my colleagues. It's like, well, we need to talk about that. I'm worried that this poor kid is going to have diabetes by the time they're 20 and renal failure by the time they're 40. And I mean, those are legitimate concerns. But I think if we're saying that our primary focus is health, then don't make it about the weight. Make it about the cholesterol profile. Make it about the blood sugar level. Make it about the blood pressure. Make it about those very specific markers. And you say, those are our targets, not a number on a scale.
Right.
And the solution is going to be, we talk about your nutritional pattern and your physical activity to the extent that those make a difference, because I think we have a responsibility to let patients know there's a huge genetic and biologic contribution to those things. And lifestyle modification is only going to change like a part of it. Whenever we are seeing even very young children in our offices or in the hospital or wherever, I think we need to be really careful that the environment we create in a healthcare setting does not perpetuate weight stigma, because right now it really does. Another term I learned from a dietitian colleague, by the way, I don't see obesity anymore. I say adiposity-related disease.
Oh, I have to think about that for a minute. Yeah, because that's a tough one to integrate into like humans walking around on the street. So adiposity as an adipose tissue, fatty tissue. So adiposity-related disease. That makes sense though, yes, because it is hard to carry around a lot of extra fat on your body because it does like convert estrogen and it causes cardiovascular disease and things. But yes, okay.
It's very,
I can get on board with that.
Specific, right? But I think that and I don't use that in front of patients. Like in front of patients, I just say blood pressure or whatever, right? But even when I'm talking with colleagues, because I want to model it, the only way I've been able to change my language is to do it over and over and over again. And that means whatever environment I'm in, whether I'm talking to patients or talking to colleagues, I'm trying not to use what I now call the O word. Using your role as a healthcare provider or expert to give this very strong message to the people you care for. Body diversity is normal and desirable. And as a healthcare provider, I'm not going to tell you any different. The other thing I think we as providers need to be really careful not to do is to praise rapid weight loss.
Yeah, it's really
because in kids who were at a higher BMI and they lose weight, that is often the first sign that something is amiss, that there's a poor body image component or an evolving eating disorder.
Or anxiety.
Yeah. And I will add that disordered eating behaviors are way more common in people with higher BMIs than people with low or normal BMIs. So we need to kind of be thinking about poor body image and disordered eating even more in our kids who live in a larger body. And I think be very careful not to praise weight loss that's rapid in a kid who has a larger body, because it just perpetuates that weight stigma and weight bias internalization.
Dr. Kumar shared 2 new terms since your medical training. The first is this concept of weight bias internalization. That's our own interpretation of what a certain body weight means. Like when we assume someone who is on the heavier side has poor self-control or that they're sedentary, that's a bias. The language we use with our patients conveys our personal bias about weight. And that's what Dr. Kumar is explaining that we need to be aware of. The world is filled with weight bias internalization, so pay attention to what yours is. The second new vocab word is adiposity-related disease. When we as clinicians use that as the basis for our diagnosis, then we think in terms of the consequences. So focus on hypertension, cardiovascular disease risk, and orthopedic concerns. It's frustrating to me, of course, that we are forced to record BMI as a diagnosis at our well visits, but it's part of our agreement with health insurance contracts. They require us to categorize patients' BMI, and it forces us into these silos of thinking about weight. But now I have a new term. Dr. Kumar is practicing its use, and so can we. It's adiposity-related disease. Thank you, Dr. Kumar, for leading the way. For more from the Pediatrician Next Door, find me on the web at pediatriciannextdoorpodcast.com. If you've got a question about the weird things kids do, send an email to hello@pediatriciannextdoorpodcast.com for a chance to hear your voice on the show. I'm Dr. Wendy Hunter, and I'm the Pediatrician Next Door. This show is produced by Red Rock Music. Make sure to subscribe and leave a review wherever it is you're listening. I'll be back next time with more.